So, blessed evening to one and all. It is indeed a great pleasure to welcome one and all to the 10th edition of the Cardio-Obstetrics Master Classes. And today, this session will focus on anticoagulation management in mechanical heart valve patients during pregnancy. So, you all would agree that this is one of the most challenging area in cardio-obstetrics, and complications that are to anticoagulation during pregnancy remains one of the most important and potential the preventable causes of adverse maternal outcomes. So we are especially honored to have Professor Mark Johnson among us, whom Sir will be introducing. So this lecture will be followed by an interactive question and answer session with our esteemed speaker and discussion on this topic. And following this, the participants who are interested in the proposed multicentric study on anticoagulation strategy in pregnant women and mechanical heart valves, they are welcome to stay back in the guiding way forward. So we sincerely thank one and all. I now welcome our course director, Professor G. Justin Paul, sir, to give us a short message regarding the cardio-obstetric master classes and to introduce the speaker. Over to you, sir.
So thank you, Annie. So we have been doing this cardio-obstetrics masterclass. Most of the time it has been case discussions. And the last couple of months, I think we have not been doing it because we got too busy in the study that we are involved in. And then meanwhile, Professor Mark's idea came, and it was a wonderful initiative that he's planning. So I thought, we can have a lecture instead of a usual case discussion. And he'll be talking to us on anticoagulant management in prosthetic heart valves, particularly focusing on the low molecular heparin aspect of it. So to talk about Professor Mark, I think I did not know him much because initially, I was new to the field of cardio-obstetrics, and we were just interested in what was practically happening, that to see how to help these people. And our article got published. And one of the esteemed people usually are called to write an editorial. So when our impact registry got published in European Heart Journal, one of the three persons along with Dr. Roos was Dr. Mark, two people, Dr. Mark Johnson. So there was a time first I came to know that there is some gentleman by name Mark Johnson. And then when I started Googling him, I was Googlied. So there is so much information about him, the amount of work, the research that he has done. And so above all, then when I see him, he's such a down-to-earth person, most humble kind that we all would like to emulate. So thank you, Dr. Mark Johnson, for agreeing to share your views here. Professor Mark Johnson had his MBBS in London University in 1982. He had his MRCP UK in 1985. He has a doctorate PhD in 1995, and he has his MRC OG in 1996. So he is accredited to general medicine endocrinology. So he is an endocrinologist, internal medicine physician, diabetologist, and obstetrician and gynecologist. You can see multiple hats he wears, and no wonder you understand why he is able to, discuss all these aspects of it with such a nice mastery of knowledge. Currently, he is the Director of Research and Development in Westminster Foundation Trust. He's the Dean of Imperial College Campus. And he has also found a lot of charitable organizations, particularly Born Trust, where he helps the preterm babies. And he is a member of multiple foundations. And he has more than 250 original articles to his credit with the H index of 69. An I-10 index of 290. So it is a great honor to have Professor Mark Johnson with us. And as I looked at his resume, it runs into pages, and I'm not talking to you about all that. In the interest of time, we are so honored to have you, Professor Mark, and thank you so much for agreeing to be here. And today, I think he'll be focusing on low molecular heparin. Now, he has been treating all his pregnant women with prosthetic heart valve with low molecular heparin. And he says that the results are very, very good. And they usually monitor the peak levels and the trough levels, and they titrate the dose of low molecular heparin according to the anti-TNA levels. However, the results that we have about anti-10A levels are not very great, whatever published data. Particularly the latest paper that we published, where I and Professor Mark co-authored, that is from the ROPAC registry in the European Heart Journal, we found that the regimen using low molecular heparin was having the worst kind of outcome. In such a scenario, there are a lot of questions and concerns about the use of low molecular heparin, or why the data is not that great, and what. So, in fact, the other day when we had the cardiac problems in pregnancy, which is a big program going on once in a year, we were in Barcelona along with Professor Mark. The professor of pharmaceutical therapeutics, he was explaining so nicely why low molecular can have a very big role, and the way that it has been evaluated does not really do justice to low molecular heparin. So now I invite Professor Mark Johnson to share his views on anticoagulation in pregnancy, particularly focusing on low molecular heparin. Professor Mark, thank you, and over to you.
Thank you. Thank you for the very kind introduction, which exaggerates all that I have done. I've just been, I don't know, in the right place at the right time. But I very much enjoyed my career going through medicine and then into obstetrics. And honestly, I would have been an obstetrician from the very beginning, but I really didn't like gynecology. So I decided endocrinology was a much better idea. And then I did a PhD in the hormones of pregnancy, and I spent a lot of time on the labor ward, and the then professor of obstetrics said, look, why don't you come and do a little bit of obstetrics? Then you can be an obstetric physician who knows something about obstetrics. And I said, well, that's a nice idea. So I did it for a year and a half. And he said, look, if you do it for another little bit, you can be a consultant. So I said, okay, fine. So I did it for another little bit, being on call as an SHO, as a registrar, and so on, that you can all remember. And then eventually I became an obstetrician with an interest in, obviously, obstetric medicine, and particularly focusing on heart disease in pregnancy, which is where and what we're going to talk about today. So unless there's any questions, I think I'll just carry on and give a talk, if I may. I'll share my screen.
Please.
Thank you very much again for the lovely introduction, though. So is that working?
It's working. We can see it.
Perfect. Okay, so I'm going to talk about anticoagulation, but really the question I'm going to try and answer for us today is why low molecular weight heparin does not work. Please feel free to interrupt me as I'm going through. I'm afraid I can't see all of you on the screen, so I'll have to rely on Dr. Paul, if you wouldn't mind shouting at me and say, oh, somebody's got a question. So what I'm going to tell you first is what I'm not going to talk about. I'm not going to talk about bioprosthetic valves. We all know that they don't need to have therapeutic anticoagulation. We all know they don't last as long as metallic heart valves. I'm not going to talk about a Ross procedure, which, if you can get it, is probably a much better alternative to either a mechanical heart valve or to a bioprosthetic valve in the aortic position. And I'm not going to tell you something you know very well, that the older mechanical valves are more thrombogenic. And definitely, I'm not going to be talking to you about vitamin K antagonists, because you know far more about vitamin K antagonists than I do. So I am going to focus purely on the low molecular weight heparins. The paper to which Dr. Paul referred, the paper about the prosthetic heart valves and the management of them, published recently in the European Heart Journal 2026, looked at our experience in ROPAC about mechanical heart valves and bioprosthetic valves. Of course, today we're going to talk about the mechanical heart valves. This is the summary diagram, which is very small, so I'm going to highlight different areas for you. If you look at the mechanical heart valves, you can see that thromboembolic events occurred in 9%, hemorrhagic events in 20%, but the maternal death rate was 1%, fetal death 27%. So these are the summary, doesn't divide it up into the different patterns or different anticoagulation regimens. It pointed out that if you actually screened using, or you monitored using anti-10A levels, you had a much lower complication rate when you were using low molecular weight heparin. So this really establishes the monitoring when you're using low molecular weight heparin is essential. Here we're looking at maternal outcomes, and all the regimens which are based on low molecular weight heparin, the dark blue and the dark grey, have worse outcomes in terms of cardiac outcomes, thromboembolic events, and hemorrhagic events. So for the mother, using low molecular weight heparin in the ROPAC is associated with a far worse outcome. Conversely, if you look at the fetal outcomes, apart from early miscarriage when they're pretty similar across the piece, you can see late miscarriage and stillbirth are relatively lower in the low molecular weight heparin using pregnancies. And I'll go into this in a little bit more detail in a minute. If you look at the review by Rohan D'Souza, it actually makes this message clearer, I think. If you start on the left here, and again, the writing is so small you won't be able to see it. So for maternal mortality, you can see in blue all the VKA throughout pregnancy is the lowest. Using a sequential regimen, when you go to low molecular weight heparin or heparin in the beginning of pregnancy and then at 12 weeks go back to VKA, is intermittent in terms of maternal mortality. And you can see that the rates in people using low molecular weight heparin seem to be higher. Similarly, for thromboembolism, and perhaps even clearer, the rates in the VKA based throughout pregnancy are lowest, intermediate in the sequential regimen, and highest in the low molecular weight heparin regimen. But in terms of fetal loss, you again can see they're higher in the VKA throughout, intermediate in the sequential, and lowest in the low molecular weight heparin. And in terms of embryopathy and fetopathy, that pattern is reproduced. What I find interesting is that the whole aim of the sequential regimen is to avoid embryopathy and fetopathy, but the rates in some studies are still quite high. So the aim of that sequential regimen is not being realized, perhaps as fully as we would expect it to be. If we look at the summary diagrams, again taken from the same paper, you can see in terms of mortality, the message I was producing there or suggesting to you there, that is lowest in VKA, intermediate in sequential, and highest in low molecular heparin is made more clear. Similarly for thromboembolic events. For major bleeding though, low molecular weight heparin is out there on its own. The rates are seen to be much higher, proving really at one level that low molecular weight heparin is an effective anticoagulant, and rather strange that we see the excess of thrombosis and mortality in the low molecular weight group. Cardiac events in the review were similar across all different treatment regimens. Fetal loss again, much lower in the low molecular weight heparin group. Fetal anomalies, lower in the low molecular weight heparin group. And the other two groups, which of course are of interest to me as an obstetrician, I'm not going to go into. So overall, we conclude that for VKA has the lowest maternal risk, highest fetal risk. For sequential, it's intermediate maternal and fetal risk. And for low molecular weight heparin, highest maternal, lowest fetal risks. That's very broad, and I want to look into this in a little bit more detail. So I want you to focus here on the blue. The blue are the VKA antagonist throughout pregnancy. And on the right here, I've put the actual corresponding figures. So for the period of pregnancy, the mortality using VKA throughout is 0.9% in Rohan's review. The annualized rate is 0.5%. And if you look at the fact that the pregnancy only lasts for 9 months, it's 0.35%. So even using VKA throughout pregnancy, you have a 3 times greater mortality than you would expect to have had if you were not pregnant. For thromboembolism, the rate in the reviews is 2.7%. When you're not pregnant is 1.3 annualized, or 0.9 if you consider 9 months. So again, the rate of thromboembolic events is 3 times greater than it would be if you were not pregnant. In terms of bleeding, interestingly, the rate is 1.3% during pregnancy. And when you're not pregnant, nearly 2%, but again reduced for the 9 months, 1.35%. So the risk of bleeding is almost equivalent to if you were not pregnant. To me, this suggests that perhaps we're not anticoagulating with the VKA antagonists as effectively as we could. Mortality is higher, thromboembolic disease is higher, but bleeding risk is equivalent. And given that you're pregnant and your risk of bleeding in any case is higher, it suggests to me that perhaps there's a little bit more space to anticoagulate more effectively to reduce mortality and reduce thromboembolic disease. However, if we look at the rates of fetal loss, and please just look at the top here, you lose your pregnancy in 35% of the time if you're on VKA throughout. So in other words, in 3 pregnancies, you lose 1. You'll have 2 live births for 1 fetal loss. If you use the sequential regimen, for every 5 pregnancies, you lose 1, or you have 4 pregnancies that work out and 1 you lose. And if you look at low molecular weight heparin, the ratio is for every 12 pregnancies, you lose 1. So if you're getting pregnant and your aim is to have 2 live births, it's going to take you more pregnancies than if you're on VKA than if you're on low molecular weight heparin. So you're going to have to get pregnant more frequently. And if you consider the slide previous, you can see mortality and thromboembolic disease, valve thrombosis, is much higher if you are not pregnant, if you're taking VKA, implying that the more times you're pregnant, the greater the risk. As we speak, we have some very clever statisticians who are looking at this to be able to work out where equipoise lies between the fact that you have to have more pregnancies if you're on a VKA to have a successful live birth than if you're on low molecular weight heparin, and where then the balance lies in the lack or the imbalance in efficacy, if you like. So again, going back to the question of why is low molecular weight heparin so poor for mothers? Why doesn't it work as well as we would want it to work? And again, if you look at the summary figures in that paper, in the ROPAT paper, and again, this is too small, so I'll make it larger for you on the side. Again, re-emphasizing, if you monitor compared to not monitoring, the thromboembolic events are much lower in the monitored group, less than 10%, compared to nearly 20% in the non-monitored group. If you look at the frequency of monitoring, every week versus to every 2 weeks to every 4 weeks, there's no really clear pattern. Again, if you look at the target levels, whether you use a therapeutic range of 0.6 to 1, 1 to 1.2, or another regimen, there appears to be no set pattern. You could argue that we do more tests in people we're more worried about, and we have a more aggressive target in those people we're more worried about, and therefore it's not really equating like with like, and this may explain why we see no pattern with the frequency of testing nor the target. However, it is clear that if you spend more time in the therapeutic range, whatever that therapeutic range you're aiming for is, you have a lower rate of thrombosis or thromboembolic disease. So from this, we're saying that if you monitor your thromboembolic events are lower, the frequency of testing and target range do not seem to impact the thromboembolic risk. And the greater the percentage of tests which are in range, whatever range that might be that you're aiming for, then the lower your risk. So if we consider how we can interrogate why low molecular weight heparin doesn't work so well, I'm going to look at dosage, I'm going to look at monitoring, and I'm going to look at the target range to start off with. And to keep me on track, in the top right corner, I'm going to place a D for when we're talking about dosage, an M for monitoring, and a T for target. So if you lose track, you'll just have to look at the top to see what I'm talking about. So what low molecular weight heparin dose to start with in pregnancy? Well, we know somebody who has a DVT or pulmonary embolism, we start at 1 milligram per kilogram twice a day, and that's our standard start dose. The ESC recommend 1.25 milligrams per kilogram twice a day. The British Society of Haematology is similar dose. But actually the mean dose of low molecular weight heparin that you will use, and I'm talking about enoxaparin all the way through here, so forgive me that I'm only focusing on one, otherwise I'd spend all the talk talking about the different doses for each different type of low molecular weight heparin. If you look at the average requirement, it is 1.35 milligram per kilogram. So I feel that we should be starting at a higher dose, but being very quick to test the efficacy of that dose after you've started it. If you look at how does the low molecular weight heparin dosing change through pregnancy, you can see here that it gently rises through pregnancy. And this maintains a steady state of anticoagulation as judged by the antifactor 10A levels. And this is a nice paper coming out of South Africa. I think it's Johannesburg. They looked at 48 pregnancies, all managed on low molecular weight heparin, and also reported 5 pregnancies on VKA throughout pregnancy. And incidentally, in this series, they had no valve thromboses at all, which was very impressive. I might be lying to you. It might have been 1 valve thrombosis, forgive me, but I'll come to the paper anyway to emphasize that point a little bit. If you look at the dosing changes, and this is the response in the different trimesters of pregnancy to 40 milligrams as a single dose, or once a day dose, sorry. In the non-pregnant, you can see the antifactor 10A is 0.5, taken at around 4 hours post injection. In the first trimester, it's about 0.42. In the second trimester, about 0.38, and in the third trimester, about 0.32. So you can see that the efficacy of a single dose of low molecular weight heparin changes quite dramatically as you advance through pregnancy. If you look at the actual clearance, how much you clear, what volume you clear of low molecular weight heparin as you go through pregnancy, you can see that it increases quite dramatically to a peak just at the end of pregnancy. And if you look at the volume of distribution, you can see that that increases again quite similarly over that course of pregnancy. And again, if you look at the response to 40 milligrams, it is as I just described. But looking at 1 milligram per kilogram taken twice a day, you can again see that the peak level of antifactor 10A activity declines as you go through pregnancy. So it's quite clear that it's your requirement for enoxaparin increases as you go through pregnancy if you want to maintain a similar level of anticoagulation. To emphasize this point, you can see here on the bottom line, when you make a weight-related dose at the beginning of pregnancy, but do not alter it, that the levels of antifactor 10A activity decline. However, if you correct on a weight-based pattern, forgive me, you can see it remains relatively stable. What about once a day versus twice a day? Well, in a once a day regimen, you will get a higher peak and obviously a lower trough. On a twice a day, you get a lower peak and a higher trough. So again, by using a combination, whether it's once a day, twice a day, 3 times a day, and your aim to keep the low molecular weight heparin in the therapeutic range, you would need to have a minimum of twice a day. And sometimes I'm using 3 times a day in order to make sure that the trough level remains within the therapeutic range. So what can we conclude from this? I believe we should start at 1.35 milligrams per kilogram twice a day. And as the requirements of low molecular weight heparin rise through pregnancy, we should be adjusting this dose using an antifactor 10A level. And I believe that should be both peak and trough, but I'll talk about that in a minute. Current recommendations are to use low molecular weight heparin only when you have access to an antifactor 10A assay. It is possible to use weight, and as I've just shown you, a weight-adjusted dosage does seem to keep the antifactor 10A levels standard or constant, but there is no comparative papers or studies looking at a weight-based versus an antifactor 10A-based adjustment to dosage and the efficacy in terms of risk, in terms of valve thrombosis, maternal death, or in terms of antifactor 10A levels. So now we're going to talk about monitoring. And you can see on the right here is the assay we use, but I'll come on to that in a second. So the question we're going to ask first is, does monitoring with antifactor 10A make a difference, and how should it be monitored? Again, the writing's too small here, so you can see this is bleeding rates looking at a prophylactic low molecular weight heparin dosage. If you're looking at bleeding rates here in people who are not monitored, you can see that there is no impact on the risk of bleeding. if you look at the ability to prevent thrombosis, if you monitor and adjust the dose of low molecular weight heparin, you will reduce the risk of thrombosis, rather like our ROPAC data. If you look at the dose adjusted to peak, however, this does not reduce your risk of a thrombosis. Intriguingly, if you look at the dose adjusted according to the trough anti-factor Xa level, and you adjust your dose of low molecular weight heparin, you will reduce the risk of thrombosis. So here we're beginning to see what is important. The peak level does not seem to determine your risk of thrombosis. Rather, it is the trough level. So how does monitoring make a difference? Well, as we're going through here, you can see a beautiful, beautiful curve when you can see enoxaparin levels rising and the levels of anti-factor Xa beautifully constant throughout. I have to confess, this was our experience of monitoring during pregnancy. And well, I can only say that we've become far more aggressive in our monitoring program now. And our results are much more like this area on the left than they are this rather higgledy-piggledy area here. But it's interesting that just actually making the effort in the ROPAC to monitor reduces the risk of thrombosis. And we did not have one thromboembolic event or valve thrombosis in our 14 pregnancies that we reported here. And again, it is to re-emphasize the ROPAC data that says to monitor reduces your risk of complications. So in another study, they looked at a systematic review of anti-factor Xa monitoring. And it looked at prophylactic dosing strategies. And it said whether you used a weight-based dose, a fixed dose, or an anti-factor Xa adjusted low molecular weight dosing pattern, it did not affect either the risk of thrombosis or safety. But I'd ask you to remember that this monitoring was based on the peak, not on the trough. If you look at people who have had a thromboembolic event during pregnancy, you can look at a weight-adjusted low molecular weight heparin approach or a weight plus anti-factor Xa adjusted. And that provided similar results in terms of efficacy and safety. If you look at pregnant women with a mechanical heart valve, the reviewers comment that they saw thrombosis and bleeding when the anti-factor Xa was within target. But again, I would emphasize, this is peak. It's not trough, it's peak levels. So we use a calibrated chromogenic anti-10A factor assay. And it very simply looks at antithrombin 3, which is an endogenous factor, as you know, endogenous anticoagulant, which is activated by the heparin, which then binds to the activated factor 10A. And the assay works by looking at the residual activity and the ability, therefore, of the low molecular weight heparin to inhibit the anti-factor 10A levels. I say calibrated for it has to be calibrated for each type of low molecular weight heparin, but the assay remains the same no matter which type. So how should we be monitoring? Well, timing. Timing is key. When do we look for the peak? The trough is easiest, obviously just before you're going to give the next injection, but the timing of the peak is actually very important. This is looking at 4 different low molecular weight heparins. The one with the open circles, this one sort of one from the bottom, is enoxaparin. So our advice is to test between 3 and 4 hours. And for enoxaparin, you can see it's just after the peak, just going down. Some people say we should be testing at 5 hours. And indeed, one of the leading experts at the CPP, the Cardiac Problems in Pregnancy, said it should be between 3 and 5 hours. And I think you can see quite clearly here that if we use that for enoxaparin, we will definitely miss the peak if we take our level at 5 hours. And if we then alter the dose of low molecular weight heparin or enoxaparin on that basis, we will be over-treating. Rather, you could say we should be doing it around the 2 to 4 hours or 2 to 3 hours, because that's where the peak is, or maybe 2.5 to 3.5. With other other forms of low molecular weight heparin, you can see that this is where we are at 3 to 4 hours. We miss the peak tremendously. Here you can see if we go from 2 to 3 hours, again, we miss the peak. And if you're doing 5 hours, then you're far off the peak, and again would advise an increase in dosage, which is not appropriate. So with your timing of when you take your anti-factor 10A level is critical to the advice we give as to the dose for low molecular weight heparin. These last two graphs are in non-pregnant people. This one is in pregnancy. So if you look again, 3 to 4 hours, you can see for enoxaparin through the different trimesters, we are picking up that peak almost exactly. The 5 hour, again, would be too late. And the 2 to 3 hours would be too early. So during pregnancy, the 3 to 4 hour timing for enoxaparin is exactly right and where we should focus our attention. What about peak alone or trough? Well, we have seen so many papers and so many headlines which say, look, in spite of being in the right therapeutic range for the peak levels, we still see complications. Well, I think we've thought about that, and maybe the trough is the answer. And this is to re-emphasize the review of Wu et al., which looked at the prophylactic dosing, showing that when you alter the dose according to peak, you did not affect your therapeutic efficacy, whilst when you adjusted it according to trough, you did improve the outcomes. So another piece of evidence that we should consider doing peak and trough. Yuri Alkayan looked at the levels of trough according to the peak levels. And here he was looking at peak levels of between 0.7 and 0.79, and 70% of the trough levels were out of range. Same between 0.8 and 0.89. Same between 0.9 and 0.99. Emphasizing that if you don't assess the trough, you are going to miss a whole period of time when you're not anticoagulating effectively. Here, when you're looking at a peak of between 1 and 1.2, 40% are out of range for the trough. Greater than 1.2, then only 5% out of range. The ratio to peak and trough actually improves as you go through pregnancy, but not sufficient that you can predict the trough from your peak measure. This really emphasizing that we should measure both peak and trough. And this is the conclusion from that paper. They're saying as many as 80% of patients had a subtherapeutic level as the trough. And the Yu Ting paper proving that changing your dosage according to trough actually has benefit in terms of risk. What about frequency? Well, we've shown this quite nice picture here where you can see the gradual increase. And you could argue, well, maybe you should do it every 4 weeks. Personally, I think I agree with the Society for Maternal Fetal Medicine in the United States when they say we should monitor every 1 to 2 weeks. I monitor every 2 weeks, and if I change the dose, then I monitor every week until I've achieved stability, and then I go back to 2 weekly. But we have no comparative data, almost inevitably, I'd have to say. So in conclusion, timing-wise, we would say the peak level should be taken at 3 to 4 hours post-injection, the trough before the next injection. We would say you should measure both peak and trough, and the minimum should be 2 weekly and more often if you're changing the dose. What about target ranges? Well, this is what they say in the Society for Maternal Fetal Medicine. The trough should be greater than 0.6 and the peak should be 0.8 to 1.2 for aortic valve and 1 to 1.2 for mitral valves. But then all these headlines keep coming up that despite being in the therapeutic ranges that we've just described there, complications are occurring. So the latest BSH, the British Society Haematology recommendation, is that we should be keeping the peak levels between 1 and 1.4. I feel that we should really keep them between 1 and 1.5. Really, for the low-risk group, 1 to 1.2, like aortic valve. For mitral valve, right-sided valves, 1 to 1.5. And trough, 0.6 for the low-risk group and 0.7 for the high-risk group. testing a minimum of 2 weekly and more often with a change in dose. And just to summarize that, not to summarize that, two other points which I know you're going to ask me about, so I'm going to preempt you. Do I believe that dosing a warfarin dose or a VKA dose of less than 5 milligrams is associated with a lower risk of embryopathy, fetopathy? I would say that the evidence is not sufficient to rely on that currently. And do I believe that we should have or should add aspirin to low molecular weight heparin? No, I don't think we should, because if we look at the ROPAC data, 60% of those people who were given aspirin and low molecular weight heparin experienced hemorrhage, much, much higher. Agreed, they didn't have a valve thrombosis, but they had a much higher risk of hemorrhage. So at the moment, I don't think the data support us using aspirin in combination with low molecular weight heparin. So this was where I was going to pause, and then I was going to go on to the study we're proposing to do. I'll stop sharing to see if anybody wants to ask any questions at this point.
Thank you, Professor Mark. In fact, it was a very clear demonstration of what has been published so far in terms of low molecular heparin in prosthetic heart valves. You told us how the peak levels may vary according to the trimester and may vary according to the agent that is used. You also shared that how measuring a peak value and a trough value could mean different. How a peak value can protect us from bleeding, while a trough value identification may protect us from thrombotic episodes. And so you talked to us and you've given a clear hypothesis as to why probably the low molecular heparins did not do well in the earlier data, earlier studies, and what was not done. And you have really brought your hypothesis now for the MHVIP study that for these reasons, if we do a peak levels and trough levels and monitor accordingly, you may have, as always, a better fetal outcome and also an improved maternal outcome, which could be equivalent to that of vitamin K antagonists. You clearly highlighted that 1 in 3 mothers on VKA lose their pregnancy, which will be a big advantage if low molecular heparin comes into the picture and is providing us a good maternal outcome as good as VKA. So in this background, dear friends, I think we have about 60 to 70 participants. I'm sure you'll be having a couple of comments or questions to make. And before Professor Mark moves into discussion about the MHVIP study, it is open for discussion. Any questions you can ask? Professor Mark, to start with, I'll ask you one question. Is it true that more often you do the tests, higher is the risk of thrombosis? More often you do tests and more often you do monitoring, more often you do the changes, higher is the complication rate.
I mean, it's difficult to know whether you're doing more tests because you're more worried. So with a mitral valve, right-sided valve, you're going to do more tests because you think, oh my goodness, this is a high-risk person and you want to push it. But I don't, in my experience, we have not had a valve thrombosis when we've been quite aggressive with our monitoring. And I monitor, as I say, every 2 weeks and then weekly when I've changed the dose. So in my experience, no, I don't find that more aggressive monitoring leads to a greater risk. But I do think there is that question of, are you monitoring more frequently in a high-risk person? So you may actually see that more frequently.
And what is the percentage of vitamin K antagonists use in the United Kingdom?
In our center, we don't use VKA. Occasionally, we will do sequential, but that's very rare. We're virtually totally now using low molecular weight heparin, but using it in a very probably aggressive. Some of my colleagues tell me you are over anticoagulating people, and they're going to die of a stroke. And I said, well, what do you mean by that? And are you aware of the data? Do you know what actually we're trying to prevent, and what is the risk that we're trying to prevent. In the UK, the latest UCOS, for example, 2017, I think it was, the maternal mortality was 9%. And people seem to forget the risk of a mechanical heart valve during pregnancy.
We have a couple of questions in the chat box. Dr. Vignesh has asked, I don't know, are you able to see this? Yeah.
Yeah.
Is there any guide as to how to adjust the dose when through the peak or trough is not achieved? When you don't get the desired peak or trough value,
Yeah.
how do you adjust now? Do you increase or decrease? What proportion, or how do you, is there a guide?
I mean, it's a very good question. And it'll depend really on how much you're on at the base and how far out you are. There's no sort of set rule. I think the one thing I would say is that when I can't get my trough into the therapeutic range, then I will change from BD to 3 times a day dosing regimen. And that enables you to have a lower peak, but a higher trough. And that, I think, is the key. Getting your trough consistently in the therapeutic range is the key to reducing the risk of valve thrombosis.
Thank you. Dr. Harikrishnan has asked, is factor 10A level measurement standardized in India? Yes, it is standardized. Availability, it is not widely available, but big corporate hospitals and institutions do have it. The cost, it may vary between 6,000 to 8,000 or 4,000 to 8,000, depending on which hospital that you are doing it. Rati, she has asked, in patients receiving TDS LMWH dosing, when should this regimen be considered? What administration timing is recommended? And how should anti-10A level being monitored? So, in the thrice a day regimen.
So I think the question was if we're not in the trough, it's really going to a TDS. I would use the TDS when I can't get my trough level into the therapeutic range. But I would use BD if I can get my trough level into the therapeutic range.
And which one is better? Unfractionated heparin, low molecular heparin. In some places, anti-10A levels are not available in India. Available, and how do we monitor if YKA is less than 5 mg? Should we change or continue? So, what is your experience or views on use of unfractionated heparin? Your experience as well as what the data shows.
Well, if you look at the sequential regimens, which are a mixture of unfractionated and low molecular weight heparin, then it looks like, and I can only say from the ROPAC data, it looks from the ROPAC data that the low molecular weight heparin is worse than the unfractionated. I feel that's probably because the low molecular weight heparin is not being used appropriately. And where you're using unfractionated, so in this hospital, for example, I occasionally try and persuade my midwives to use unfractionated heparin, and they look at me aghast. They have no idea what they're doing, and it's a total disaster. So I rarely now ask them to use unfractionated heparin because they're just not used to using it. If you're used to using unfractionated, then you will be very familiar with using it and you'll use it well, and it's as effective in terms of risk of thrombosis. So the difficulty with the low molecular heparin is harder to reverse, obviously, because it's a subcutaneous injection. It's being released continuously. You need repeated doses of protamine to reverse it, whilst you can just stop the unfractionated heparin, and within 6 hours it's gone out of the system. So they're different. For a patient, much easier. Obviously, you don't have to admit, you don't have to keep them in. For a low molecular heparin, you can use subcutaneous unfractionated, but I don't think that is as good or as stable in terms of anticoagulation that we see with low molecular weight heparin. But honestly, your experience using it is far greater than mine.
Dr. Praveen has asked, when do you start the low molecular heparin? In the first trimester, once the pregnancy is confirmed, or even before when they are planning the pregnancy?
It's a super good question. I was only thinking about that when I was looking at the talk. I mean, our current practice is as soon as a woman is pregnant, we change them over to low molecular weight heparin. Ideally, that is at 6 weeks, because obviously what you're trying to avoid is that increased risk of miscarriage associated with the VKA. So the sooner you can do it, the better. The problem with changing somebody before they get pregnant is they may take quite a long time to get pregnant. And so they're on low molecular weight heparin for quite a long time before they can conceive. And so in practice, we just say in our preconception counseling, as soon as you have a positive pregnancy test, let us know. And I will swap them over immediately. They have a positive pregnancy test and keep them on it until we know whether it's viable and so on. Yeah, that's what we do at the moment. If you look at the papers, though, for example, the paper I referred to out of Johannesburg, the mean time that they converted to low molecular weight heparin was 11 weeks and 3 days, meaning that that early pregnancy loss was not reduced at all, because really at 12 weeks you'd flip back to VKA if you were doing a sequential regimen. So I think as soon as they get a positive pregnancy test is the time we need to actually convert them.
So the question is, what is your concern about sequential regimen?
So the sequential, if you look at the fetal loss rate, it is actually relatively high. So you're not achieving what you're hoping to achieve, which is to protect the fetus by going on a sequential approach. My other concern is that you change from VKA to a heparin, low molecular weight, unfractionated at the beginning, say 6 weeks for sake of argument. You then change back again at 12 weeks. And it's those points of change which prove to be really points of vulnerability in terms of losing effective anticoagulation. So my worry with the sequential is the repeated changes. And I'd rather be on just low molecular heparin all throughout, because you avoid those changes and you can continue all the way up until just before you're going to deliver on the low molecular weight heparin. If you're on VKA, of course, you're going to change to again at 36 weeks. So you have three change points with the sequential regimen, which I think are the points of vulnerability with it. And I don't believe the sequential regimen provides fetal protection as much as we would want it to.
So two things you say that one is the multiple points of change, the sequential therapy, and the second thing is sequential therapy fails to achieve that kind of fetal protection. Now,
as much as we want, yeah.
So now for the second point, would you consider 6 to 16 weeks instead of 6 to 12 weeks? You think if you do 6 to 16 weeks, will it have a better fetal protection?
It's a super good question again, but we just don't know. We really don't know what the rates of embryopathy are, what the rates of fetopathy are. And this is one thing that we will answer with our study. We will be able to say, these are the rates of embryopathy, because we'll be seeing people early on. We'll be able to say, these are the rates of fetopathy. And because we're going to do MRI scans, we will be able to pick up perhaps lesions which we didn't even know were there when we look at the brain MR of the babies.
Thank you. A couple of more questions. Dr. Adrian, I think, has asked, during labor, which one would you prefer, LMWH versus heparin infusion?
So if you're inducing somebody prior to labor, obviously once they're in labor, you would not want them on anything at all. If they're very high risk, or moderate to high risk, I would have them on unfractionated heparin, because you can start the induction, stop it, and 6 hours it's out of the system. If they're low risk, I would just simply stop the low molecular weight heparin.
Okay, a couple of more questions are coming. We have cases of patients who bleed while on low molecular heparin.
Yeah.
Do you stop the low molecular heparin? If so, how long do you stop it? And when do you resume this dosage? And what dosage do you resume?
Yeah. So, I mean, that's a very, very good question. I mean, there isn't a right answer to this question. So it would depend on the severity of the bleeding. It would depend on why the person is bleeding, and how long do you stop? It depends on whether they're continuing to bleed, and what dose would you restart them at? It depends on what the anti-factor 10A levels were. If you were within the therapeutic range, I would put them back on that therapeutic to get them back into the therapeutic range. Nobody dies from bleeding as a general statement. Obviously bleeding into the brain, maternal brain, yes. But in our hands, hemorrhage is not the cause of death that worries us. It's the valve thrombosis. It is the embolic phenomenon that actually causes death far more frequently than hemorrhage. So yeah, it's a very good question. There is no right answer, but it's you just have to judge clinically, I'm afraid. I wish I could give you should do this, this, and this, but it's just not like that. In obstetrics, everybody knows it's just not like that.
A pregnant lady, 100 kg weight, needs 135 mg twice a day. Needs monitoring 2 weeks, once peak, once trough.
Yeah, so when I started, I would then, after the third dose, I would check the active factor 10A peak and trough and then adjust. So the good thing about low molecular heparin, it works pretty quickly. So you can get a quick judgment of how effective it is, then weekly until you're stable, and then 2 weekly once you're stable.
I think the last two questions, while adjusting the dose of enoxaparin to achieve trough and peak values, are there concerns with continuing to escalate the dose of enoxaparin beyond 2.5 mg per kg body weight?
I mean, as long as you are monitoring the anti-factor 10A, then no, I don't have concerns doing it's whatever dose you need. Some people need more. I have to say, I mean, 2.5 milligrams per kilogram twice a day would be quite a big dose. I have never seen anybody need quite that much. But yeah, I mean, as long as you're monitoring it, then I think you have no choice but to effectively anticoagulate.
And Dr. Arden has asked one more question. Is there a safe dose limit for acetron like 5 mg or warfarin? This is about the vitamin K antagonist he's asking. For warfarin 5, we say that it's fetal safe. So what about acetron, acinocumarol?
Yes, no is the answer. I mean, we know we've seen in the series in the ROPAC, we reported again fetal anomaly associated with doses of less than 5 milligrams. So probably the rates are lower, but no, I don't think there is a safe VKA dose or that we can use.
So thank you, Professor Mark. And I think I should thank the audience for the great interaction. You had asked a lot of questions. Thank you so much. And now we'll move into the second part of the program. Professor Mark is initiating the low molecular heparin in prosthetic heart valve and pregnancy study. So all those who would like to stay back, who would like to participate in the study as a potential investigator, who you may have questions so that Professor Mark can answer, you can consider doing the study in your institution. So I request you all to stay back. And those who would like to leave, who do not want to or do not have the necessary requirements to participate in the study, thank you so much for being here. Your presence actually adds a lot of meaning to today's program. Thank you so much for giving your feedback. Please communicate to us for any feedback about that. We'll be more than happy to receive feedbacks from you. And I'll again hand over to Professor Mark for the presentation on MHVIP study.